Okay, there we go, Mohammed. Can you hear
Okay.
me?
Yes, I'm hearing you.
Okay, well, let's go ahead and get started. I did all the questions go through? I'm sorry, I sent them so late.
No, no, everything is good. Yeah.
Okay, great. Yeah, well, we had some very interesting questions this time. People have had a year to sort of process what's going on, and just personally, I've seen a lot of issues related to gastroparesis. So I'm glad to see that some of those questions popped up.
Definitely.
So I will let you go ahead and start with whatever question you would like to address first. And
Okay.
thank you so much
So,
for being here. And I'm sorry, introduce yourself. Hi, you're not just hi, I'm
okay.
Mohammed.
Yeah. Hi, everyone. I am Mohammad Bashashati. I am an internist and also a researcher. My research focus is on gastrointestinal motility disorders, and I work on projects on patients with gastroparesis, irritable bowel syndrome, cyclic vomiting syndrome, rumination syndrome. And I also see patients with gastrointestinal problems in my clinic. I'm happy to be with you today, and I thank Amanda for arranging this session.
Thank you so much for giving your time and your knowledge to us and your willingness to take all of our questions and answer them as best you can. And I
Okay.
do want to remind people that this is you do need to consult your physician or your medical provider. Um, this is obviously we can't give you medical advice, but we will try to guide you as best we can so that you can maybe go seek the care that you need. Okay, thank you so much.
So I have the questions here. We had multiple questions about mast cell activation syndrome.
Yeah.
The first one is for those of us experiencing mast cell activation symptoms, how can we rebuild our gut biome without triggering a histamine response? Yogurt, fermented goods, and probiotics pills all seem to cause reaction and issues. So my answer is MCAS or mast cell activation syndrome is a diagnosis of exclusion. There are lots of misconceptions about diagnosing MCAS, uh, which have affected many patients and impaired their quality of life. Its key feature and its symptoms start with uh, episodes of systemic anaphylaxis with concurrent involvement of at least two of the four organs. These four organs are cardiovascular system, which patient may have hypotension, increased heart rate, or syncope or near syncope. The other organ is respiratory system that the patients have wheezing symptoms, shortness of breath. The third one, which is also important, is dermatologic features with urticaria and pruritus and angioedema. And the fourth one is the gastrointestinal system, which can present with diarrhea, nausea, vomiting, and crampy abdominal pain. So for the diagnosis of MCAS, one should have at least two of these systems involved at the same time. Fatigue, fibromyalgia-like pain, pride appearance, ill appearance, edema, rashes, tinnitus, means enlarged lymph node, constipation, chronic low back pain, headache, mood disturbances, anxiety, PTSD, depression, hypothyroidism, hyperthyroidism, sometimes are misdiagnosed as MCAS. So we have to consider that. For the diagnosis of MCAS, you have to be seen by a clinical immunologist or an allergy specialist. And it is very important to perform some tests to rule out other conditions. The diagnosis is based on measuring serum or plasma levels of tryptase. If you have done tryptase test and a tryptase level in your blood was high, or after having an event, it increases, you make the diagnosis of MCAS. This is very important. You cannot make the diagnosis of MCAS just based on symptoms. So you should have two organs involved and do a test to rule out other conditions, and at the end, do a tryptase test. It is very important. And a key diagnostic part in MCAS cases is responding to medications which inhibit the mediators released by mast cells, like histamine. So if you feel you have MCAS, you are taking H1 blocker, histamine 1 receptor blocker, plus minus H2 blocker, histamine 2 receptor blocker, and you don't respond to these treatments, as well as other medications in rare conditions like aspirin or steroids. And if you take this and you don't respond well to this, you don't have MCAS. It is very important. There is a misconception about MCAS and a new entity which is called histamine intolerance. Some patients may have histamine intolerance. The diagnosis of that is very difficult, because in these patients, we have lack of an enzyme in the GI tract, which is called D-amine oxidase in the GI tract and other organs. So in D-amine oxidase, it metabolizes histamine and decreases histamine level. But unfortunately, there is no commercial test available at this point to measure this enzyme. In order to make the diagnosis of histamine intolerance, you have to be involved in a research trial, and they measure your D-amine oxidase level. You were asking about rebuilding the microbiome for the treatment of MCAS. I think that's not the best way to treat this condition. There are multiple good medications which are targeting the mediators and the receptors that the mediators from mast cells are released. They inhibit those receptors, and you will get good responses to those treatments. First, you have to try those. And regarding some probiotics which trigger histamine release, and some of them are not, you have to keep it for the next step of treatment, because there is no solid research on that data. Means nobody confirmed that this specific probiotic increases histamine level and the other one not. So don't rely on changing your microbiome in order to addressing MCAS. If you really have it, try to see a clinical immunologist or allergy specialist to get a definite diagnosis. And there are multiple ways to address these conditions with H1, H2 blockers, sometimes aspirin, and in rare cases, steroids. So if somebody with real MCAS or histamine intolerance has abdominal problems like bloating, pain, diarrhea, or nausea, vomiting, I would treat the patient with H2 blockers, and we can add another compound which is called cromolyn on top of that, and that will address the GI conditions. But before that, we have to address other organic involvements, rule out other reasons, and also, of course, we have to make the definite diagnosis of MCAS. There are multiple websites that they are linking our symptoms to MCAS, but it is not simple. And you have to be seen by a clinical immunologist. And taking natural medication is not always safe. It means sometimes the synthetic medications we target a specific receptor are safer than going with a natural medicine that we don't know where it acts. Of course, this is my point of view because I'm means a clinician. Maybe those who work on herbal things, they believe in something else.
Well, and that's, I think, I'm glad you brought that up. I think that's another question that this, is further down, and that it's a good segue into this. Um, what we don't realize is that whether it's a medication or something that we perceive as natural, everything is a chemical. Everything has a pharmacodynamic effect. Everything has a pharmacokinetic effect, and it affects all of us differently.
Exactly.
So we have to take that into consideration. So thank you. With that, you kind of covered that next one, but uh, I'll let you go ahead and go into the next question.
Okay, the next question was, for those of us who use H2 blockers like Pepsi to have control MCAS symptoms, again, about MCAS, you have to go to an immunologist. Don't make the diagnosis of MCAS from the beginning, okay? Is this safe to use long-term, or should we take occasional medication holidays to avoid becoming dependent? Let me tell you, there are no long or short-term health risks of using H2 blockers. And I have to remind you that there was an H2 blocker which was called ranitidine Zantac. It is out of market now because of its link with cancer. But for famotidine or Pepsid, which is the most regular one and mostly available one in the market, and nothing has been confirmed, and we easily use that for our patients. Remember, if you have a kidney failure problem, you have to decrease the dose of Pepsid. So regularly we use 40 milligram daily, but in kidney problems, we go lower, usually 20 milligram, but please see your doctor to adjust your dose. There is no risk, and they are for a long time in a market, at least decades.
Yeah, they're fairly inexpensive, either over the counter or as a prescription.
Exactly.
So.
And means in the market we have a Pepsid which is 20 milligram over the counter. You can play with the dose up to 40 milligram daily, maximum recommended dose. But again, your doctor should decide. You shouldn't decide. Yeah.
Exactly.
Yeah.
And I guess this next question goes into what we were discussing in terms of natural versus medication, and yeah, I'll let you take it from here because I have a degree in anthropology and archaeology, so by the time I get to people, it's a little too late.
Okay, so there was a question which was a lot of long callers are taking a variety of over-the-counter supplements to treat diagnosed deficiencies and or hopefully improve some of their symptoms. Can you share if there are any common supplements that shouldn't be taken together, like zinc and iron, or work together better when they taken together? Let me tell you an important thing here. During COVID-19, we saw lots of supplement toxicities, vitamin D toxicity and zinc toxicity. When you take too much zinc, it decreases copper in your body. My neurologist colleagues are seeing patients who are coming with numbness, weakness in their extremities. They do all workup, which come back negative, but at the end, just one question answers why this happened, and that was zinc. We shouldn't overdose that. It's very important. From now on, you have to try to supplement all these nutrients through your diet. It is important. Means the general adult doesn't need a supplement pill daily. About vitamin D toxicity, everybody, means some people are continuing taking 50,000 units of vitamin D weekly.
I found out the hard way that's a terrible idea.
Yeah, you shouldn't do that. Means if you don't have deficiency, you shouldn't continue taking it weekly. You go to
Your,
monthly.
your
Okay,
kidneys will hate you.
exactly. So how to protect from COVID? You have to get vaccinated and you have to use your mask. This is not the supplement
Yeah.
that protects you.
And stay away
About
from
taking supplements, you have to
isolate.
talk to your doctors. Some people may need it. Some people who have bariatric surgery or vegetarian, they need some kind of supplements. But of course, they have to talk to their doctors. And at the end of this session, I will send a link to Amanda that can put in a group from NIH that has all informations from individual supplements. You can go and read about them. There are lots of ideas beyond this session. So I'll send a link. And there is also a website from Health Canada about how to adjust your diet. Of course, I will send that link as well.
Okay, thank you.
I think those are very helpful. And remember, natural does not mean safe. A regular multivitamin daily is fine, but you shouldn't overdose that.
Yeah, exactly. Don't take
I
more
hadn't,
than...
yeah. Yeah, the other issue is iron toxicities. We see patients with iron deposition in the liver and other organs. You shouldn't do iron supplementation if you have iron overdose. Some patients have anemia, but they think that by taking iron, they can solve the anemia issue. It's not always the case. There should an anemia workup should be performed before supplementing with iron. You may have B12 deficiency. You may have folate deficiency. You may have problem with your bone marrow. You may have bleeding issues from GI tract is a major one. You have to consider all this.
Well. I'm sorry, I think there's a bit of delay, but yeah, I've been seeing ferritin issues as well post-COVID. But again, you need to see a doctor and have those labs drawn.
Yeah, so you have to run an iron panel to make sure your iron ferritin is low and transferrin saturation is also low. Then you make the diagnosis of iron deficiency and you can supplement that. So it's different for pregnant ladies, it's different for kids, it's different for vegetarians, for those who have lost of the piece of intestine or after bariatric surgery, there are different. But in general, means a regular, if you want to take a regular multivitamin from the market would be fine.
Yeah, and it's amazing how simple things that we think are innocuous, too much vitamin A, and that's something that's very easy to take too much of.
Yeah.
So just because it's natural doesn't mean it's good in any quantity.
And now zinc is very important because I have seen cases with zinc toxicity.
Yeah, I'm starting to hear more of that as well.
Yeah, with diet, you can adjust all your needs. So we will put the link later.
Yeah, thank you so much for that.
Yeah.
Yeah, so, and some of the rest of these are really getting into a lot of what I'm seeing in terms of motility issues. So I'll let you take it from here. Go for it.
Sure. So the next question was, I recently had a possible reinfection with mostly upper respiratory symptoms and body pain. There was no vomiting or diarrhea, but I did have nausea, which I attributed to the constant sinus drainage. As a result of that the nausea, I was only able to eat 5 or 6 very small meals over a 10-day course of acute illness. I did drink enough fluid to stay hydrated, but when I weighed myself afterward, I had gained 8 pounds. How frustrating. How is that possible? Okay. First of all, you are mentioning that you had reinfection. It is very important to protect us from getting reinfected with the virus by wearing mask and taking precautions. And you are mentioning that you had upper respiratory symptoms, which means that you were probably infected by Omicron virus, which mainly attacks the upper respiratory tract. And you are mentioning that you had a nausea because of sinusitis and drainage in the back of your throat, sinus drainage. Definitely it causes nausea, but the nausea will not last longer, means because sinusitis should be a short condition, it shouldn't long last. And if you have chronic posterior nasal discharge, you may have allergy symptoms, and you can go with some antihistamines to decrease that secretion, and of course to decrease other symptoms, including nausea. You were eating 5 or 6 very small meals over the 10-day course of acute illness. So for all patients with motility disorders who cannot tolerate food, we always advise them to take small pieces of meal 5 to 6 times a day. So you were doing great in terms of that. You cannot have 3 full large meal. Yeah. And you were saying that you drank enough fluid to stay hydrated. Here is my question. Was this water? You have to make your drink water, means don't go with juice. All of them, they have sugar. So you have to count calories in those.
Not coffee.
Coffee doesn't have calorie. Coffee, if you don't put any milk or sugar in it, is fine, as long as it doesn't give you some other side effects like tachycardia. But
that's another town hall.
Yeah, exactly. So, but means as long as your drink doesn't have calories, is fine. Remember, some patients should be on fluid restriction. That is very important. Cardiac patients with renal failure should be on fluid restriction. Patients with liver failure or cirrhosis, they don't need to be on fluid restriction. They should mainly be on salt restriction. Salt restriction goes with kidney failure, heart failure, and liver failure. But fluid restriction is for heart failure and kidney failure, not for liver failure. Okay, that is important. So if you drink too much salty drink, and if you eat too much salty food, that may cause water retention in some cases and weight gain. Of course, the first reason for gaining weight is calorie, means sugars, carbs, and the second issue is water retention, which goes with too much fluid in some cases and too much salt in others. I hope this answered the question. Yes. Well, what do you think?
Yeah. I think I think that really answered it quite well. So.
Yeah, because this question had multiple parts, so
yeah,
I had to cover everything.
Let's see. and this one really, this next one gets to a lot of what I'm seeing, and the reason I contacted you,
Uh-huh.
I'm seeing a lot of motility issues, and
Mhm.
you seem like a good person to ask.
Okay, thank you. So many of us are experiencing slow motility and feeling nausea, fullness many hours after eating. What are some safe non-pharmaceutical ways to help promote GI motility? Okay,
That's a difficult one.
again, okay,
Yeah,
yeah, this is an important question.
it is.
Uh, means slow motility. Again, motility disorders of GI tract are diagnoses of exclusion. What does that mean? That means that you have to rule out organic conditions with endoscopy or other modalities like radiology imaging, and make sure there is nothing wrong with your means organs. For example, some patients with gastroparesis may have problem with their pylorus. Pylorus is a sphincter at the end of the stomach, and it doesn't relax or it doesn't open. And also there might be a lesion there, an ulcer there, rarely a tumor there, which doesn't allow food uh, to get empty from the stomach. Some patients may have problem with swallowing, so means dysphagia, problem with swallowing. In these conditions, we also need endoscopy and at least an imaging, a radiology imaging, when we give them a contrast to drink and we take picture from their esophagus uh, to rule out organic conditions like a tumor, ulcer there. Reflux also may cause problem with swallowing, and it may cause dysphagia. That is very important. When we go down, we may have a problem with colon motility, which presents with constipation, or if it is fast, it could be diarrhea. So whoever comes with long-lasting constipation, especially at ages more than 40-year-old, we consider doing a colonoscopy and rule out conditions like colon cancer, because they may start with constipation, with changes in bowel movement, rapid changes in bowel movements. So this is important. And let's talk about the nausea phenomenon. Not only slow stomach, but also rapid stomach emptying, which is called dumping syndrome, can be associated with nausea and vomiting. So one symptom of dumping syndrome is nausea. It's not because of emptying, it's rapid emptying. And these patients may have means dizziness, and drop in blood sugar, diarrhea right after eating. For nausea, I categorize it based on when it happens. Means if it happens just a few minutes after eating food, so it is different than when it happens later. If it happens later, means in 2-3 hours after eating food, it could be a condition which is called gastroparesis, of course, after ruling out other organic conditions. And if nausea and regurgitation happen right after eating, it is called rumination syndrome. Again, after ruling out organic condition. So patient is on a table eating with friends and suddenly feels nausea in front of others and rushes to the restroom to throw up. And what comes up is undigested food. So and they usually regurgitate them. This is called rumination syndrome. And they have problem with diaphragmatic muscle movement. So uh, you have to consider this. It's not gastroparesis. Emptying of the stomach might not be affected. And it happened right or within 5 minutes, 10 minutes of eating. And these patients get embarrassed. They don't go to eat with others because they may get nausea right away. Gastroparesis patients usually have some underlying conditions like diabetes. Uncontrolled diabetes can lead to gastroparesis because these patients have neuropathy. Neuropathy can affect your hands, legs with numbness, and also it can affect your stomach and also your colon. So in a colon, diabetes may cause diarrhea or constipation based on which nerves it's affected. It's a dangerous condition, and controlled diabetes can affect your GI tract, your kidney, your heart, your neurons. So it's good to keep it under control. And compliance with the diet and your medication is very, very, very important. And measuring your blood glucose at least daily.
Yeah.
At least daily.
Yeah, yeah, your daily and also your A1C.
Yeah,
We are
exactly.
seeing a lot of diabetes post COVID.
Yeah.
Fortunately, for some people, I've seen it dissipate over time, but not everyone. So,
Okay. About if COVID causes diabetes, I'm not sure
yeah,
about
that's
that,
yeah,
but it might be diagnosed while the patient was seeking medical care for a COVID
yeah,
when they randomly check the A1C or
yeah,
glucose, but it might link as well. And
yeah.
yeah, we don't know about it. Maybe you have to ask an
Yeah. Yeah,
endocrinologist
I'm
about
actually I'm working with someone else. I was talking about it with another person, but I was like, "Hey, I need you over here." I'm trying to get that person over here
it.
right
Yeah,
now. Um,
great. Yeah,
and
let me tell you one thing more about
oh yeah, please do.
gastroparesis. Gastroparesis can also happen after viral infection. Okay,
Yeah.
it's like post-infectious gastroparesis. So we have also post-infectious irritable bowel syndrome. It's a new entity, and we have to study. We don't know about it. So a viral infection may trigger gastroparesis uh, and may cause delay in gastric emptying or change in uh, the neurons of the gut-enteric nervous system or the central nervous system and may affect your GI tract and its motility. They were asking about non-pharmaceutical, non-pharmacological ways to help promote GI motility. So there are very good medications we can treat you with um, uh, for nausea, for problem with means constipation, but naturally maybe means ginger tea can help with nausea, but that's not the treatment. I'm telling you, that's you shouldn't overdo it as well because it has side effects. And for bloating, I suggest peppermint, mint. Uh, mint tea helps with bloating. Um, apple cider vinegar, a tablespoon in a glass of water once a day if you can tolerate a tablespoon in a glass of water, not more than that. After meals, not empty stomach. This is important. So they may help with bloating because of changing the microbiome of your gut, but be careful about natural medications. There is another entity in nausea category, which is called cyclic vomiting syndrome. I have to remind you about that. Cyclic vomiting syndrome comes with vomiting attacks in a cyclic fashion. So patients may end up with nausea and vomiting every week, every 2 weeks, and they go to hospital for that. They may find some release with hot shower. So hot shower may help them. But again, they have to take some medications to address their condition. On top of cyclic vomiting syndrome, there is another condition which is called cannabinoid hyperemesis syndrome. Whoever uses cannabis for a long time, it may downregulate the cannabinoid receptors in your body, and it may trigger symptoms like cyclic vomiting syndrome. So if you have cyclic vomiting syndrome and you are smoking cannabis or using cannabis, you have to bring that down to help with your symptoms. Okay. Any other thing, Amanda, you want me to add?
No, I think you really covered a lot of that well, and that I think that will speak to a lot of people. I've especially in the past 6 months, I've seen an uptick in gastroparesis and other motility issues. So thank you.
Yeah, for gastroparesis, you should make the diagnosis with a test which is called gastric emptying test. This is a 4-hour test.
Okay.
Yeah, it's important to do that test to make the diagnosis and also to label somebody as gastroparesis. We give a radio-labeled meal to patients, a sandwich to eat, and we take a picture from their stomach 30 minutes, 1 hour, 2 hours, 3 hours, and 4 hours after the meal. And if it is slow, it doesn't empty, and we see still the sandwich is in the stomach. So with that, we have some numbers to make the diagnosis. And if it passes the threshold, we label the patient as gastroparesis.
I actually worked in nuclear medicine for 2 years, and I loved it.
Great.
It's a different, for those of you who aren't familiar with nuclear medicine, it's not taking a picture of the anatomy of your body. It's actually taking a picture of your body's function, what it's doing, this completely intangible thing. So it's pretty cool.
Yeah, it takes picture from the sandwich, which is in your stomach.
Yeah.
So,
okay, we've got a long one here. I'll let you tackle it. Go for it.
Yeah, I had severe COVID pneumonia in July 2020. Hospitalized, unfortunately, in ICU, home oxygen for 13 months, developed interstitial lung disease and mild pulmonary hypertension. Also developed secondary adrenal insufficiency due to steroids. I also continue to have GI issues, primarily abdominal pain, epigastric radiating to the right upper quadrant, nausea, loss of appetite. I was started on Carafate, which is sucralfate, before meals and at bedtime, and Protonix twice a day for a small ulcer in December 2020. Symptoms improved but didn't go away until December 2021, for approximately 1 year, when they again became severe. I had an EGD, means endoscopy, that showed another ulcer and severe inflammation and gastritis. For over the next 2 months, I followed a very strict, very bland, easy to digest 6 small meals per day diet. And we changed my PPI to Dexcellent and added probiotic daily. I just had my repeat EGD last week. The ulcer has healed somewhat, but the gastritis is still severe with significant inflammation, erythema, friability, and erosions based on the endoscopy report. H. pylori was negative. Why isn't my gut healing? What else can I do to promote healing? Do I need to explore the possibility of MCAS, mast cell activating syndrome? I do not have any cutaneous symptoms. I do have a follow-up appointment with my GI to discuss this, but not until April 4th. In the meantime, I'm miserable, unfortunately. Okay. So let's address this question in different parts. So you still have ulcer. Okay, so your condition is called refractory peptic disease, refractory to medication. How do I manage these cases? So you were on PPI, proton pump inhibitors, twice a day, which is a maximum dose, and you still have ulcer. Number one, we have to check if you were taking this PPI in the right way. So if you are on BID PPI, you should take the first one 30 minutes before breakfast, and the second one 30 minutes before going to bed. Okay, this is a way how you should take a PPI. For pantoprazole is 40 milligram 2 times a day, Protonix that you were on. What I do if I see a patient with refractory peptic disease, I increase the dose of PPI or proton pump inhibitors to the maximum dose, which is 2 times a day. For pantoprazole is 40 milligram 2 times a day. For omeprazole, 20 milligram 2 times a day usually. Some people, they go over 40 2 times a day, but in my practice, I don't go much than 22 times a day. And for Dexalant is we have 30 milligram daily and 60 milligram daily is a maximum dose. I go high first for at least 8 weeks. And I may consider adding another acid reducer medication like Pepsid, 20 milligram to that. So I will add, in my patients, I add Pepsid and then follow the patient up and see what happens. Some patients are rapid metabolizers of PPI. We don't have any commercial test to assess that. And that's the reason I add an H2 blocker like Pepsid on top of that. And if it doesn't get better, if the symptoms do not get better, if gastritis doesn't get better, the next test is for Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. They have to measure your plasma or serum gastrin level, which is a mediator which triggers acid release from the stomach. And also they can do a test which is called secretin stimulation test. With secretin, they try to increase gastrin and they measure that. That's Zollinger-Ellison syndrome. And of course, you have to rule out a Helicobacter pylori infection. You can do biopsy of your stomach, which probably was done during your endoscopy. But if you are on PPI, the way that I biopsy my patients is different than those who are not on PPI. So you should biopsy the top part of the stomach, because with PPI, Helicobacter pylori travels to the body, part of the stomach, to the upper part of the stomach. So you have to make couple of biopsies in a body and corpus part of the stomach, or you can use other modalities like urease breath test, or stool antigen test for Helicobacter pylori. And of course, for urease breath test and stool antigen for H. pylori, you have to stop Protonix PPI 7 days before the test, and you have to stop antibiotics 4 weeks before the test. And that's it is because of this that we test after treating for means H. pylori. We wait 4 weeks, and after that we do the stool antigen test. So let me summarize. First, I rule out H. pylori. Second, I increase the dose of PPI. Third, uh, I may add an H2 blocker on top of that. And fourth, I rule out Zollinger-Ellison syndrome in patients with refractory ulcer or refractory peptic disease. Regarding MCOS, I talked about MCOS at the beginning of this session. This is not MCOS. You should have two organs involved in order to make that diagnosis. And of course, if you take an H2 blocker, it may address some of the MCOS manifestations. But I have to remind you that for whatever I told you, the doses and everything, you have to talk to your medications, to your physician, because it's very important to adjust the medication dose based on your body condition, based on your kidney condition, liver condition, and you shouldn't increase it by yourself.
Yeah,
okay.
that's always important to add in there that it's not just one system that's being affected, it's a lot of other systems as well.
Yeah. Yeah, but for ulcer, it's mainly the acid in the stomach, and we have to suppress that. And if a patient is drinking alcohol, should stop it. If smoking, should definitely stop it. They may make ulcer worse.
We are
And
a
the
wild
other thing,
partying group here, so.
yeah, I'm telling for general, yeah, general.
Yeah.
And yeah, this is very important to stop smoking and alcohol. And remember, if you are on high dose steroids and if you are taking pain medication, they may contain NSAIDs, or steroids may also cause gastritis. So you may take a medication for your pain, joint pain, but it may have some NSAID like naproxen, like high dose aspirin, like ibuprofen. They may make your gastritis worse. So check the label of your medication and make sure they don't have those. It's very important.
Yeah, and even medications that maybe you've taken before and haven't had problems with post-COVID. I had a medication that I've taken off and on over the years, and for whatever reason, this last round, oh my gosh, it hit me differently. So don't assume that if you haven't had problems with it before, it's, I don't know. There's still a lot that we're learning post-COVID. And unfortunately, a lot of us are the first to go through the jungle with the machete making the path. So cheers to us.
Yeah.
And so we've got one question left here.
So for long haulers who do not seem to be improving, do you see this as a lifelong health issue? And do you see it leading to further future health problems? Actually, it depends. If you are on supplemental oxygen, if you have permanent lung injury, if while being in ICU you got kidney failure and it is still sustained, and unfortunately if you had a stroke due to COVID-19 with means problem with weakness and movement issues, they may unfortunately continue. So if there is organic damage, they may continue. But if it is functional, there are ways to address the situation. So it depends to the patient and the symptoms and the organs which are involved.
Yeah, and I think that can be very difficult for those of us who got sick in that first wave. In the United States, in January in 2021, we passed a $1.15 billion bill that funds study through the NIH. And a lot of us know that we'll participate in this, but it might not benefit us. It benefits the people who come after us. So, but we're here. Let's do it. If
Yeah,
they can't help us, let's help those who come after us.
yeah. And here, if you remember, we did
Yeah.
2 studies on the members of your group and other groups as well. We looked at a condition which is called post-COVID functional gastrointestinal disorders. Our study is under review now for publication. Hopefully it get accepted soon. Among our participants, we found that during acute phase of COVID-19, having gastrointestinal symptoms was linked with severe outcome, means being in ICU or hospitalized or having kidney failure, liver failure. So whoever had GI conditions during acute phase had a worse disease. And also we found that loss of smell was protected. Means whoever had loss of smell had a less severe disease during the acute phase.
Okay,
so they
wow.
ended less in ICU.
I just did a little bit of, I didn't realize for 4 months that I'd lost any sense of smell. And then on the 4th of July, I couldn't smell fireworks.
Oh, great.
And I realized the candles I bought were not bad. It was my nose.
Yeah, so yeah, but loss of smell apparently protected from being in ICU and having severe disease.
I
Uh,
got
yeah.
lucky. And I know I got lucky. I have asthma, and it was very scary at first. I didn't have insurance, and I would wake up. I would go to bed every day thinking, please let me wake up. So
yeah, and the other issue that we found in this study, and I want to share with you, which is very important. In phase 2 of our study, we looked at anxiety and depression with 2 standardized questionnaires, which was GAD-7 and PHQ-9 questionnaire. We found that 33% of the participants unfortunately had anxiety, and 45% were suffering from depression. This doesn't mean that all COVID long haulers have this problem, but among our participants, we found these numbers, which is quite high. 33% anxiety, 45% depression.
Yeah,
so
you were doing this very early on too.
Yeah. So
when it felt like we were fumbling around in that first year, trying to figure out what's going on. Just write everything down. Everyone write everything down. Take note of everything.
Yeah. So this is an important issue to address. Besides GI and other systems, psychiatric aspects of COVID-19 are very important. And if you feel sadness, if you have any anxiety, please discuss with your doctor to get treatment for that.
Yeah.
Because you have to come back to your regular life. 45% is a high rate.
It is very high.
Yeah.
And I'm actually working with several organizations right now. We recognize that it's not just a depression problem. We do have a suicide problem in long COVID. And we're working on setting up something more substantial for that.
Yeah, right they have to work on it. Yeah. It means suicide comes with a severe depression. So, yeah, I found that this was an incidental finding because the focus of our study was GI system, but we said, let's put this in and assess that.
Yeah.
I wanted to bring to your attention.
Thank you.
If you feel any sadness, if you feel you are anxious, I know it's a difficult time, the life is not easy for everybody. Please go and discuss it with your doctor and get the problem addressed and return back to your life.
Yeah.
Anxiety and depression, they can stop people from functioning well. It's not all COVID. There are other aspects in the life, but we can address that. There are ways to control that. There are ways to live more healthy.
And I'll post there's another website that has a wonderful list of resources. If you are in crisis, there are crisis lines for you. And just know that more is coming. More is coming for us. Okay.
Yeah. And the other finding of our study was some of our patients develop IBS, they develop dyspepsia, they develop cyclic vomiting syndrome, or even fecal incontinence after having COVID-19. So we don't know why, but see your doctor if you still have any of these symptoms. Yeah.
And we do have a group kind of working behind the scenes. If you need help finding a physician in your area, please feel free to reach out. In expectation of a wave coming in post holidays, I added quite a few moderators. Most of us have some type of experience in either social work or in some aspect of medical care, and we are glad to help you find a physician as best we can. We want you to get the care that you need and deserve.
Yeah. So I would like to thank you again for arranging this meeting, and thanks everybody for listening to us. And thanks, I would like to thank those who participated in our study as well. As soon as our manuscript gets accepted, I will send it to you, and
thank you.
Probably you can put it on the website.
Oh, look, we kept it at an hour this time. That's good.
Yeah. Yeah. Any specific question that you have in mind that I can address, Amanda?
I can't think of anything. One quick thing that comes to mind with ondansetron, or not ondansetron, Omeprazole. Is there a limit on, like, because I know that there are some studies saying, hey, don't take too much of it for too long. Is there something we should bring up here?
And let me tell you about that. There are multiple studies. They are saying that taking omeprazole or pantoprazole, oral PPRs for a long term, may cause a bone fracture, hip fracture. It doesn't cause hip fracture. Number one, it causes cancer. It causes kidney failure. It causes infection, pneumonia. But the findings are not solid. The findings are not solid. So as long as your doctor is recommending this, and as long as you are the lowest effective dose, it is fine.
Okay.
So for example, if a patient has Barrett's disease with severe reflux, they have to be lifelong on pantoprazole PPI to protect them from going to severe complications like cancer. So if you consider risks and benefits are more. And I usually, in my patients go down and keep it at the lowest effective dose. I may start high, but later on, based on their symptoms, I decrease it. And if they are totally fine, and if they don't have any underlying condition like Barrett's disease, I may ask them to take it PRN or as needed. So that is when everything is better. And for patients who have reflux symptoms, besides manipulating the acid with PPI, lifestyle is also important. You have to
Yeah.
find food that triggers the symptoms. And some people, they don't tolerate coffee, tomato juice, spicy foods.
Sriracha sauce.
Yes, so whatever you cannot tolerate, you should try to avoid that. You cannot 100% stop those.
Come on, Mohammed,
But
YOLO. You only live
yeah,
once.
yeah, try your best. But lifestyle and also means weight loss is important in reflux disease. It's very important to decrease abdominal pressure. If you decrease the abdominal pressure, the pressure in your abdomen by decreasing weight, that will help with reflux symptoms. And 2 to 4 hours after eating, you should then go to bed. That's also important to
Yeah.
decrease reflux symptoms.
Yeah, and that's such a tricky one with long haulers because we deal with that post exertional malaise where, oh my gosh, we do this. Well, but really, we're going into year three of this. We've been in this 2 years, and we've already, I think we've already done so much work in understanding what this virus does. And we owe a lot of that to a lot of the other post-viral communities as well. So thank you, those of you who've built this pathway for us, um, and for the internet coming together to bring these researchers together, to bring patients to you. Thank you for your work as well.
Yeah, regarding the post-exertional malaise, if it is still there, you have to perform a pulmonary function test
Yeah.
by a pulmonologist and differentiate between functional disorder and chronic lung damage
Yeah.
because of severe COVID-19. So they can do X-rays, CT scan, and pulmonary function test. If it is because of asthma, if it is because of
Hmm.
bronchospasm, they can help with medications like
Yeah.
bronchodilators, and that will get better. Post exercise malaise, it could be because of your heart or could be because of the lungs. So it's good to see a cardiologist and to address whether you have any problem with the heart
Yeah.
as well or not.
Yeah, and if you
Yeah.
can find a long COVID clinic near you, and please, everyone, feel free to message me if you've had a good experience, a bad experience, a neutral experience. We have, of course, there are lists out there of all of long COVID clinics. Can you imagine this 2 years ago? No one even believed us, and now we have long COVID clinics all over the world. But I also want to hear your experiences with them. If you had a good experience, a bad experience, I want to know so that we can sort of bring people together. Like, hey, they really put two and two together for me here. So let's find out who's doing what.
Yeah. So, and post-COVID conditions are recognized by CDC now,
Yes.
and they have a definition for that. There is an ICD code for that.
Use your
So,
9.9.
yeah,
Guess who did ICD-10 coding for a long time?
yeah. So,
Yeah.
yeah, when
Sorry.
if you have symptoms more than 4 weeks of COVID-19, that can consider post-COVID
Yeah.
problem. Yeah,
And
and we are
moving,
studying post-COVID functional GI
yes.
disorders.
And I thank you for it so much. But with that, thank you so much for your time today.
Thank
And
you.
yeah, just any future studies, just you are always welcome in our group. We just
Yeah,
appreciate all your work. Okay.
yeah. Thank you so much. Thanks for everybody.
And please
To
give my greetings
for
to your colleagues.
yeah. Thank you.
Okay. Have a great day.
You too. Take care. Bye.
Bye, Mohammed.
Bye, everyone.